All right. Thanks for sitting down and suffering through this. I gotta hand you some stuff. It's today we're gonna do a quick 5-minute presentation on the Easy IO, which we use here at work for IO therapy. I got a few handouts. First is our protocol on it. So for the mom manual, and that's got the AFD specific stuff, and I'll probably be going over that. I'm going to steal your copy. And then we're going to have some evals at the end. We're going to... No, you can just share with Jared if you don't want.
Okay.
And then I'm just going to go through the Teleflex IO PDF. It's the, I'm sorry, not the PDF, but the PowerPoint training. That's the best material for the training. Anyway, let's just go through the PowerPoint first, and I'll kind of narrate some stuff. There's a couple of short videos, and then I'm going to talk about some stuff that's pretty specific to us as well, and just kind of the tips and tricks that I've learned along the way too. So, and feel free to chime in if you can think of anything.
It's always a good review.
Yeah, it is. So we use the Easy IO IO system here. It's what we use it for practically is when we can't get an IV in a sufficient amount of time, or sometimes we'll concurrently shoot an IO and an IV at the same time. Typically this is for cardiac arrest situations, and situations when we're using them in conscious patients. This is something that we're going to try to go to, not as a last-ditch effort, but when we know we're not going to be getting an IV in the time that we need to administer medications and fluids. For our purposes, that's what we use the IO for. The anatomy and physiology, this does make a lot of difference, honestly. And if you don't put this in the right place, it's never going to flow right. And I've seen a lot of guys shoot them too low, and they never flow right. So you have spongy bone at the end of the spongy bone in the middle at the end of the bone, and you've got the hard, solid bone on the shaft of the bone. When you're shooting an IO, it always pays to go higher rather than lower. I've seen people try to shoot lower, and this starts to get a lot more dense as it gets lower down on the bone. If you get that, you know, it doesn't matter how much pushing and squeezing you're going to do, you're just going to get a poor flow rate out of it. And whenever we're shooting for these landmarks, we are shooting for this spongy marrow at the top, and that's what allows us to get the good flow rates out of it. This is fluoroscopy. We always have questions, how fast is it really getting into the system? Anything that we can put through an IV, we can put through this. And frankly, this is how fast it runs in the system. It's amazingly fast. It's just as fast as an IV. When this thing first came out, I had my doubts too, but this thing runs really, really quick. That's how fast the medication is in the system. You can see the anatomy there and how close it gets there. This is through a femoral head, or I'm sorry, a humeral head one. But we have multiple sites we can put this through. I'm not going to go through this video because it's pretty long. But what they're talking about here is the proximal humerus site ID. The bottom line is, and you can do this to your partner, if you take somebody's arm and you put them across their abdomen, and you find the notch in between the deltoid muscle and the pec muscle, and then you put your hand there like a karate ninja, and then you take it and you put it midline on the arm, and you take your thumbs and you go right to the middle of that, and you move them up until you feel the neck of like the golf ball, where the golf ball starts. You go 1 finger breadth above that, and that's where you shoot. This, to me, is the hardest site to find on people. Absolutely. Like, we do tibias all the time. They're nice bony prominences, even on big people, but those are next to impossible to find, especially on big people. We do have some other sites, and I'll go through that here in a
That's
second.
funny, they're all big bone.
I know, big bone people. This is our primary site, tibial tuberosity, 2 finger breadths below the tibial tuberosity. Again, I like to go 1 to 2 just because I like to stay up in the spongy bone. And then an alternate site is down near the medial malleolus. It's 1 to 2 finger breadths above the bony prominence on your inside of your ankle, basically. And you can see the site right there. Kids, The proximal site is the same on the tibia, and the alternate site is also the same, but you're talking about 1 finger breadth on there. So. This is the distal femur site. This is the alternate site for peds. You want to avoid the growth plate in peds, so you're going to go. You're going to try to find that kneecap area, patella area, and you're going to go 1 finger breadth below the distal femur on a kid. They're going to be a lot easier to feel on children. These are our 3 sizes. The thing to note on all these is the black marks. These are 5mm marks on these needles. The one that's most important is the bottom mark. When we go to insert these things, we insert them into the skin first, and then when they hit bone, that's when we start to drill. If this last mark disappears before you hit bone, it's too small. So that's why we have the long one for bigger people. If we get in and we can't hit bone by the time we hit this last black mark, it's a no-go. So, because the tissue itself is going to pull the IO out, most likely. So we have a 15mm 15 gauge, 25mm, and 45mm. This is obviously for our pediatric patients, 3 to 39 kilograms. The 25 gauge is 25mm for most of the people we deal with, and then the 45mm. A lot of times you're going to use these more often in the proximal humerus head, especially again with the bigger people.
And in my experience, you just figure out you need the yellow by the blue not showing the line. It's not
right.
Like you look at a patient and go, oh, I should go yellow. You just try the blue, and if it doesn't, you know.
Yeah, a lot of us have done this long enough where we kind of get a ballpark. We know which one is going to work for us. Yeah. So, needle set selection, just like we talked about before. When you go to insert this into the site, you're actually punching through the skin first until you feel the tip hit bone. And then you run up the drill, go straight in.
So as long as you got 5 mils when you have...
It's not
necessarily 5 mils, but
as long as you can see the last black mark.
Yeah.
And I've got you guys have all seen these, but...
Yeah.
And on the yellow, like if you go to try the yellow first and you still see a bunch of those lines, you may need to go back to the blue.
Yeah. Because you may go too far.
Yeah.
This is just showing how to drill it. So once you get to the bone itself, you just run up the drill and just kind of slowly run it in. We don't carry these sets here at the AFD. We usually just secure, if we do secure, these things are pretty secure on their own. So they do sell these are their commercially available devices, but I've seen people accidentally snag these things and move an entire leg off to the side. I mean, when we first started using this, there was talk of using 2 Curlix rolls next to them and taping them together.
Just leave it open so you can see it and don't mess with it.
And especially in cardiac arrest, I mean, honestly, don't take the time to do it. These things are super duper.
If it's in right, it's not going anywhere.
Right. Let's see. This is talking about the insertion. Oh, yeah, this one's worth watching.
Usually they're pretty far down if we're doing it.
Let's see.
I've seen situations where
Supposedly it's the pressure of the push,
Yeah.
the baroreceptors.
I think this is the video of them actually putting it in. So, I can't believe this guy submitted to this.
Yikes.
I know, right?
I can handle pretty much anything.
I know, look at the look on his face, right? You're about
You
to
can
do
feel a
what?
little bit of poke here, okay?
Punches it through, hits the bone,
That's it.
and that's it. You unscrew it out of the introducer.
That's it.
That's it, man. So,
Easy money.
come with $20 now. Get a case of Keystone.
a few items of prep. We have the Easy IO sets. We do keep these short sets with each of them. They come inside these little prepackaged deals. You can't really see it, so I usually pre-prime this with saline, and then once you screw this set on with 10 mils of saline, you want to blast that as hard as humanly possible. It is going to be absolute, pure, unbridled hell for somebody who is awake. So if you're nice and you have time, you Yeah, you pre-medicate them with 20 to 50 milligrams of lidocaine beforehand. But if you don't, I've given this to people who are conscious, and it is true. They come off the bed. It is the worst scream you've ever heard in their life. It's horrible.
Almost recommended grade when guys go on screen.
Yeah. So for kids, it's 5 to 10. I'm sorry, 2 to 5 mils. Adults, it's 5 to 10 mils. Usually 10 mils works pretty good. What you're trying to do is you're trying to blast out all the debris from the spongy area. And then you want to infuse as fast as humanly possible for cardiac arrest. A lot of times we'll use an infusion bag, which we keep on the rigs, or which comes to worse, we can use a blood pressure cuff. Yeah. I'm not going to get too deep into this stuff. This is documentation and removal. We don't do a lot of removal here. And that's their thank you, blah, blah, blah. Okay, real quick, I'm going to go over the protocol, the stuff that's appropriate for us to look at. So we are cleared for all the sites. This is bottom line. There also is one other site I wanted to talk about, and that's the proximal humerus head. So if you're laying somebody down and you lay their hands next to their body, and what you're going to want to do is you're going to want to go above their abdomen, go all the way over, and basically find a bony prominence on their hip. So it's going to be, you've got your hip bone up here, and then what you're looking for is the femoral head right there, and that's going to be the bony prominence right here off to the right-hand side. You're going to want to shoot just for the top of that guy right there, and that's an alternate site, including the ones we just talked about. Document it. We have wristbands. These are supposed to go on to patients once we deliver them to the hospital. These are good for, the IOs are good for 24 hours. Don't forget to prep the site with chlorhexidine or betadine. We keep both of these. And I think that's pretty much the majority of it. EMT2s and 3s are cleared to do this. So, and if you have any questions when you're on a code, just ask us. If you want to do one, do it. You know, it's a good experience.
I encourage it right out of the gate.
Yeah. What's that?
What are the hospitals, how do the hospitals deal with, do they use them
They're
at all?
very used to it.
Yeah. It was like anything that we bring to them. There was a lot of
Initial, like, what is this?
yeah, you know, and wariness. You know, same with the audit, you know, or the Lucas that we use. They're kind of a, what is this thing?
But now they want it.
And now they use, well, and they use it on their own too. They use the Easy IO also. So, you know, there's other systems out there. We're pretty lucky. Our whole system kind of uses the same one. But there's the fast one, which is the sternum punch one, and there's, I don't know, the big IO or whatever it was called.
Yeah, I frankly, I think this one's the best one. I don't like the chest one. It's huge and it's got multiple needles and it's in the way.
Yeah, it looks like a torture device. So it's
Yeah.
horrible. So. Questions, comments, concerns?
Thanks, man.
All right. Thanks, guys.
Thank you.